everyone, myself Sagar, and today I'll be covering cervical vertebrae mobilization. So first, before diving into the mobilization part, let's briefly talk about the anatomy of cervical vertebrae. Altogether, there are 7 cervical vertebrae in human body, out of which there are 4 typical vertebrae, which is C3, C4, C5 and C6, and 3 atypical vertebrae, that is C1, C2 and C7. Some of the unique peculiarities of cervical vertebrae are it has got presence of transverse foramen on the cervical vertebrae, and it is the smallest and most mobile vertebrae as compared to other vertebrae of human body. The typical cervical vertebrae. So as I've already mentioned, it ranges from C3 to C6. It has got small and rectangular bodies which is wide from side to side, as you can see in this figure. It has got bifid spinous process and the facet orientation is of 45 degree. The typical cervical vertebrae also has got unique feature which is known as the uncinate process. The lateral hooks which is present at the margins of the body, these are known as uncinate process or uncus, and the transverse process of the typical cervical vertebrae has got 2 tubercles, anterior and posterior. And the vertebral canal of the cervical vertebrae, the typical one, has got triangular shape and it is also large. Moving forward, the atypical cervical vertebrae. So the first one, C1, also known as atlas, because it holds the weight or it bears the weight of skull. So it has got no body, as you can see. It has only got anterior arch and posterior arch. The posterior arch, which means it has got rudimentary spinous process, which is it does not have any spinous process as well. The vertebral canal is the largest over here, and the transverse process is the largest of the cervical vertebrae. C2, it is also another atypical vertebrae, cervical vertebrae, and it is also known as axis. It has got the tall body known as dens or odontoid process, and the spinous process is largest, and the vertebral canal is large and triangular, and the transverse process also has got anterior and posterior tubercles. The last atypical cervical vertebrae is C7, and its body resembles with the thoracic vertebrae and it is slightly heart shaped. The spinous process is large and prominent. The vertebral canal is triangular and the transverse process is thick and prominent. These are some of the images of cervical vertebrae. This is basically the typical cervical vertebrae, which has got a body, spinous pedicle, lamina and spinous process and transverse process. It has also got transverse foramen. This is how the orientation of cervical vertebrae looks like, and the images that you can appreciate, the below ones, are basically the atypical cervical vertebrae C1 and C2, first cervical vertebrae and second cervical vertebrae. Arthrology. So the joints which is mainly present in the cervical vertebrae are: number 1, interbody joints. It is the connection of intervertebral disc with a pair of vertebral body. So when 2 vertebrae comes in contact, it is a joint formed between them. Apophyseal or facet joint. It is a joint formed mainly by the inferior articulating facet of superior vertebrae with the superior articulating facet of inferior vertebrae. For your better understanding, when the inferior articulating facet of superior vertebrae comes in contact with superior articulating facet, the superior articulating facet of inferior vertebrae, the apophyseal joint or facet joint is formed. The other joints are atlanto-occipital joint, atlantoaxial joint and intercervical joint. The intracervical joints are mainly formed by these 2 joints only, the 2 apophyseal joints on the either side and 1 interbody joints. Atlanto-occipital joint, as the name suggests, occipital condyles of the skull and the superior facet of the atlas. And atlantoaxial joint, as the name suggests, it is a joint formed between the atlas and the axis. Now, the movements occurring in the cervical vertebrae. Mainly, there are number one, flexion and extension, which occurs in sagittal plane, lateral flexion to the left and right, which occurs in coronal plane, and rotation to the left and right, which occurs in horizontal plane. This is a sample video that I have added in my slide for the better understanding. So there are altogether 7 cervical vertebrae, and this is how flexion and extension takes place in cervical vertebrae. Next movement, rotation of the cervical vertebrae to the left and right, and the lateral flexion of the cervical vertebrae to the left and right. Now, the glides that we are supposed to give while performing the mobilization of cervical vertebrae. So, the first one, central posterior anterior glide. It mainly emphasizes to increase the range of motion while extending the neck. Unilateral posterior anterior glide, also known as unilateral PA glide, which is mainly given on the facet joint, either of the facet joint, either to the left or the right, which mainly focus on increasing the range of motion while doing the lateral flexion. And also it slightly emphasizes on increasing the range of motion for rotation. And the last one is transverse glide, which mainly emphasizes on increasing the range of motion while performing the rotatory movement of cervical spine. Now let's dive into the demonstration process of cervical vertebrae mobilization. So for the demonstration part, first we should ensure that the patient is comfortably lying on a prone lying position and with a pillow on their shin bone. Now, as we have earlier discussed about the 3 glides, the central PA glide, which means the posterior anterior glide, and unilateral PA glide and transverse glide. So for central posterior anterior glide, the therapist should stand in front of the patient, and the level of the bed should come at the level of the thigh of the therapist. And for the palpatory process, first we have to palpate the occipital protuberance, and after palpating the occipital protuberance at the posterior aspect of the head, now I'll gently slide down and I'll find a depression, a depressed area, which is the rudimentary spinous process of C1, or the first cervical vertebrae, as we have discussed earlier. And after palpating the first cervical vertebrae, I will use my another finger, the tip of my finger, and then the bony prominence that I will be feeling is the second cervical vertebrae, the spinous process of second cervical vertebrae. As there is no intervertebral space or intervertebral disc between C1 and C2, we will immediately find the second cervical vertebrae. And now with my other finger, I will palpate and I will find a space that's known as interspinous space between the C2 and C3 vertebrae, and after that I will find C3 vertebrae, interspinous space, C4, interspinous space, and C5, interspinous space, C6, interspinous space, and C7. So for therapist convenience, it is suggested to use a marker to mark the area or the landmarks, so that for using for other glides, it won't be necessary to palpate again and again. So if we marked it earlier, then as this is C2 and this is C3, so I'll be marking on C3. Similarly, likewise, whichever bone or whichever area you want to mobilize, you can mark it and give the mobilization. So now the first glide, that is for the central PA glide, we use the tip of our thumb, and I am giving the central PA glide on third cervical vertebrae as I marked it earlier. So on the tip of the spinous process, I'll use the tip of my thumb, and the thumb should be approximate and parallel to each other, and with the fingers I'll clasp the muscles so that it won't be shaky, and the direction or the vector of my force should be towards the eyeball, as the facet joint orientation is 45 degree. So according to the grades, the Meelan grades, now we can give the mobilization. The elbow should be extended and the force should come from the shoulder. So this is central PA glide. For unilateral PA glide, similar the way we have done for the central PA glide, we should palpate the spinous process. So now I have palpated the C3 spinous process, just lateral to the spinous process. We find the facet joint. To confirm the facet joint, we should ask the patient to flex and extend the neck. Therapist should feel the opening and closing of the facet joint, and as the therapist feels the facet joint, he now should place the two fingers approximate to each other and stabilize his hand, and then go for mobilization on the facet joint. And the last one is transverse glide. So for transverse glide, therapist should stand on the either side of the patient, and to give the transverse glide, the mobilizing thumb should be on the lateral aspect of the spinous process, and with the superimposing the thumb, the stabilizing thumb, and the therapist should be in walk standing position, and then the force should come from shoulder and the elbow should be extended, and then we should give the transverse glide. So this way the mobilization technique for cervical vertebrae. Thank you.